Okay, so good morning, everyone. This is going to be a very sort of case-based rounds. I actually like rounds where over half the slides have echocardiogram on them. It's one of the things that when I do an echo rounds talk, I want to be able to show lots of echocardiograms and make it interactive and make it practical. I think we get a lot of didactic aspects, which I think are important, but you want to be able to apply that to echocardiograms, and then as clinicians extend that to applying it to management of patients. I'm going to hopefully share with you 3 cases. There's a fair bit of data on each of them, so hopefully we'll be able to get through. And I'll try and make it more interactive, particularly in the room. So I might ask people to give their opinions. I was going to lean on the echo fellows, but there's only one here. So, two. There's Yazid. Okay, perfect. Okay. So these are the objectives that were sent along by Dr. Chow. So I'm going to review 3 cases of heart failure, either with valvular disease or LV dysfunction, and discuss some tips and tricks to fine-tuning quantification. John's online, okay. Quantification of mitral stenosis, which is the first case, and aortic regurgitation, which is the second case. And then the third case is a heart failure reduced ejection fraction patient. I was involved in the management of all 3 of the patients, particularly on the echo side as well. So just a couple of points about echocardiography and heart failure, particular valvular disease. I think we realize the importance of echocardiography. CMICS is a center of excellence for structural heart disease, so we definitely see a wide variety of valve patients here. So, patients with dyspnea or heart failure frequently have valvular heart disease, both stenosis and regurgitation, sometimes a combination of the 2. The first 2 cases are of mitral stenosis and aortic regurgitation. And as we approach echocardiography in these patients, the major questions and challenges are, is the valve condition that we've recognized by echocardiography, is it in the range of severity where an intervention is indicated? So usually we don't intervene upon moderate degrees of severity. Usually moderate to severe, ideally severe, so we're confident that the lesion that we're thinking about from a valve standpoint is truly severe. You want to have that confidence. I think the one caveat perhaps, and we don't have as much data, is in the setting of mixed valve disease. So there's some data that, for example, a combined moderate aortic valve stenosis with moderate aortic regurgitation together can cause enough hemodynamic consequences to cause patient symptoms that could drive an intervention. And then on top of that, have that intervention result in improvement of symptoms and improvement of quality and ideally longevity of life. So the real gold standards as to why we need to intervene. And then is the valve condition driving the dyspnea or the heart failure? So a lot of patients complain of shortness of breath, but is the regurgitational stenosis the driver of that shortness of breath? Do we need other investigations beyond echocardiography? Echo is not the only test that you get, although sometimes it's good enough. And then if so, which test? Then after that, is there enough evidence to support an intervention? Okay. So the first patient is a 61-year-old woman. Actually, was a patient of bautism. History of rheumatic mitral valve disease and a prior balloon mitral valvuloplasty in 2006. And this study, I think, was in the mid-2010s, like 2015, 2016. So it's well past the initial valvuloplasty. History of hypertension. And she comes to the office complaining of fatigue and increasing dyspnea, overall NYHA class 2 to 3. She's on warfarin because she's in atrial fibrillation with rheumatic valve disease. Metoprolol, Acupro for hypertension. She saw a small dose of a diuretic, Lasix, and Adalat XL for hypertension as well. In the office, she's hypertensive at 149 over 90 millimeters mercury. The heart rate is 72 beats per minute. Irregular in atrial fibrillation. Her JVP is very mildly elevated, 4 to 5 centimeters above the sternal angle with a prominent V wave. There's a slight RV lift, and she has a grade 2 diastolic blowing murmur along the left sternal border, which you'll see is her aortic regurgitation, and a soft grade 1 to 2 out of 6 inflow rumble at the apex, but no peripheral edema. So to the echocardiogram. So So this is a parasol long axis, a fairly typical rheumatic configuration. You can see the restriction at the tips of the leaflets. The anterior leaflet moves fairly well. The posterior is thickened, probably calcified, and fixed. And you can see there's reduced opening of the mitral valve. LV systolic function normal to low normal, maybe 50 to 55%, and there's abnormal septal motion. And stay tuned for rounds in January that I'm going to talk about abnormal motion. But there's a couple of reasons for abnormal motion in this patient. Here's color Doppler. So there's trace mitral regurgitation, you can see here. And there is a degree of flow acceleration through the mitral valve in diastole. So a degree of mitral stenosis, which you figured out from 2D morphology anyway. And there's a degree of aortic regurgitation, which you can't tell here, but in the end, it was quantified as mild to moderate. Zoom view of the mitral valve, color compare. There's a tricuspid valve. Mildly thickened. There's a bit of restriction. There's no diastolic doming. I suspect there's probably a degree of rheumatic involvement given the rheumatic mitral valve as well. And there's a degree of mild coaptation. And the tricuspid regurgitation is a fairly large jet, but the flow convergence is relatively small. And it turned out to be in the moderate range, so moderate tricuspid regurgitation. I've always said you got to be careful about large areas of color flow Doppler and overestimating severity of regurgitation just purely based on that. Here's a short axis view of the mitral valve. So fairly symmetrical opening as reduced this, that the sort of classic configuration for rheumatic mitral stenosis. And there's the short axis view at the mid-pap muscle level. Kind of a bit scanned into the apex a little bit here. You can see a bit of diastolic septal flapping. I forgot to mention this. Maybe a sleepy. So on top of the tricuspid regurgitation, there's this abnormal flow here. So, and if you saw the short axis flora, but do you know what this flow is here? What are the possibilities?
It's from the area of the IVC for coronary sinus. You can, if there is a shunt of some sort, you might have like a left to right shunting of some sort.
Yeah. So, and we saw that on the short axis actually. So it's actually it's fairly continuous actually. So it could be IVC flow, although it's a little bit off that. So yeah, so you'll see it on the short axis. Joshua just, I agree with you, Joshua. And that was my point, is that you can overestimate the severity of regurgitation purely based on the color flow. So I almost get blind to this and just focus at the tips and to see the area of flow convergence we quantify with PISA method. So this patient quantified their TR as moderate. But yes, if you just looked at the color flow, you might think it's severe, but you're going to overestimate it. So that's a tip for users that while color flow is useful to detect the presence or absence of regurgitation, it's probably one of the weaker techniques to look at the severity based on a number of different factors. So here's that short axis, right? So what we're seeing before on the RV inflow view is an en-face color Doppler signal from this left to right flow across the atrial septum. And this turned out to be iatrogenic from the initial mitral valvuloplasty from 2006. Although at this stage, without that history, you might think this is just a secundum atrial septal defect, which it could be. The effect is essentially the same. Doesn't matter if it's iatrogenic or true congenital. And then the other tip, don't forget that on the short axis view of the tricuspid valve, you're looking at multiple commissures, these small 3 leaflets here. So the degree of color Doppler you're going to have here is going to be higher than you get when you're only seeing 2 of the leaflets. It's very similar to the mitral valve. Color Doppler mitral valve, apical 2-chamber view is the bicommissural view. That color Doppler jet will almost always look larger for central jets on that view compared to the apical 4 and the apical 3. So I've seen sonographers call moderate MR based on the apical two-chamber view, where it looks mild in other views, and it's just mild. Here's the apical four-chamber view. So here's a continuous wave Doppler across the mitral valve. You can see the tracing here, and the mean gradient is 6 or 7 millimeters of mercury. You see the heart rate is on the lower side, 71 beats per minute. And you have one tracing for the pressure half time here, which is 1.8 square centimeters. You have to obviously average a number of them given atrial fibrillation and the irregular heart rate. 1.7 over here. We're able to trace the mitral valve area on the short axis, and it's 1.4 square centimeters by planimetry. We do this a lot on T using 3D. And actually, there is some literature to suggest that using 3D to help guide location of the tips of the mitral valve, so X-plane imaging, for example, could be helpful for perimetering mitral valve area. A pretty good tip to use 3D transthoracic probes if the image quality is good enough, at least for X-plane imaging. I'm talking about full volume 3D, but even just X-plane or biplane imaging might be helpful. So the tricuspid gradients are in the low 30s. You see the IVC is dilated, it doesn't collapse, so the estimated RA pressure is 15. So RVSP anywhere from 45 to 50 millimeters of mercury. Okay, so here's a summary of the echo report. So normal LV and RV size systolic function, or low normal LV systolic function. The RV is dilated, and the septal flattening, both in systole and diastole, although it looks a little bit more in diastole, right? The mitral valve is rheumatic in configuration. The mean gradient is 6 to 7 millimeters of mercury at a heart rate of 71 beats per minute. Atrial fibrillation is trace mitral regurgitation. And we have two measures of the mitral valve area, one by planimetry, which is 1.4 to 1.5 square centimeters, and a little bit greater by pressure half time, 1.7 by 1 to 1.8 square centimeters. There's moderate tricuspid regurgitation, RVSP 45 to 50 millimeters of mercury. Right atrial pressure is 15 millimeters of mercury, and there's minimal rheumatic aortic valve involvement, mild to moderate aortic regurgitation, no significant stenosis, and there's an ASD, probably iatrogenic with left to right flow. Okay. So the questions in this case, so what is driving the dyspnea and heart failure in this patient? Is it the mitral stenosis? Is it severe enough to drive it? Is it the atrial septal defect? Certainly looks like there's significant flow across that ASD. She's hypertensive, so could heart failure preserve ejection fraction with diastolic dysfunction contribute to this as well? Or is it multiple causes, all three playing a role in this? And specifically, in terms of intervening, is the mitral stenosis mild, moderate, severe in severity? And is the ASD a significant shunt? It is iatrogenic. There are times where you can have a significant shunt from a previous transseptal puncture, but it's a lot of transseptal punctures close over time or are small, and you don't worry about it. So what are the next steps? So what do folks think? What do folks think? Would you think the mitral stenosis is severe to the point that you think about another intervention? What do you think, Flora?
I think so. It's in the range of maybe moderate to, like, by numbers wise, and moderate to severe. There is some degree of hypertension associated with this as well. There's RV dilatation, so perhaps the ASD is also involved in this degree of hemodynamic problems in this case. I think one thing, I guess, would be if I can compare it to prior echoes to see whether there is any progression in the degree of mitral stenosis. I don't think in this case there may be some reduced flow from the degree of TR that is reducing or underestimating the mitral stenosis gradient perhaps, but it's already sort of in the moderate to severe range.
Yeah.
But I think one thing would be helpful is to understand the progression of what happened. She's clearly had mitral stenosis before. Is RV dilating more so than we would expect? Is the as a result of an ASD?
Yeah.
I think those are questions that I have in my mind.
Yeah.
Right now.
So this is obviously this is not a straightforward case of rheumatic mitral stenosis because there are other factors involved, and that's kind of real life, right? These are complex patients.
We also look at
Yeah, yeah. Well, I actually have one note on that here, but there are times where with mitral stenosis we would, because a lot of symptoms are exertional related, so we could do an exercise test just for pure exercise tolerance. There's some data on how high the gradient or RVSP could get with exercise that might signify a worse prognosis that might drive intervention. Having said that, there's no randomized studies of exercise testing to drive intervention and then subsequently show an improvement in that. And because of that, it's not a class 1 indication per se. It might be a class 2A/2B, but potentially it could be useful. Okay, so this is the way we in the past. The bottom being cut off, but this is from the ASE guidelines for quantification of stenosis back in 2009, and then there's a valve guidelines update after that. But this is I put this up in part because this is what I think a lot of us who are older in the room learned in terms of classification of the severity of mitral stenosis. This is what I learned, right? So moderate MS was an area of 1 to 1.5. Severe was less than 1 square centimeter, and mild was greater than 1.5 square centimeters from a valve area standpoint. And then mean gradients, anything above 10, some guidelines in the past would say 12 millimeters of mercury would be severe, 5 to 10 moderate, less than 5 mild, and then RVSP, so elevated, kind of mild, borderline elevated for moderate, and not elevated RVSP for mild mitral stenosis. And the usual caveats, right? There's lots of caveats. I'll talk to a little bit later about the different methods to quantify the area, the pitfalls with each of them. Nothing's perfect. And the same thing with gradient. Lots of different factors will affect the gradients as well. And gradients could be affected by a number of different factors in this particular patient, whose gradient now is in that moderate range, right? So, and in the past, we would almost never intervene with the valvuloplasty or valve replacement in a patient who we thought the mitral valve area was truly greater than 1.5 square centimeters. So a lot of intervention, like valvuloplasties, would occur in patients with a valve area of 1.4, 1.3, even though at that time the classification was that was moderate mitral stenosis. And when the mitral valve area is less than 1.5, so moderate or greater, the decision to intervene was based on the consequence of that valve stenosis, how much symptoms, what the PA pressures were, and then as well the suitability of a patient for valvuloplasty, knowing that it was less invasive than valve replacement, where the thresholds may be a little bit greater. And I think that was at least the thinking about why you would intervene upon somebody who technically has moderate mitral stenosis if it was a balloon mitral valvuloplasty. And then to Moise's point, exercise testing was recommended in patients who you weren't sure about their symptoms. Sometimes the symptom is fatigue, right? So sometimes patients attribute fatigue to short breath. It's difficult to separate the two, right? So yes.
How much does the AFib play into it? Because I remember scanning a patient once that was in and out of it during the study. They had mitral stenosis, and when I measured the gradients and the AFib, it was much higher than when they were in sinus rhythm.
Yeah, it could be related to rates, for example. So if the heart rate increases with the AFib, definitely, as the rate increases, that diastolic filling time decreases. There's less time for that blood to go from the left atrium to the left ventricle, and gradients will almost always go up in the presence of fixed stenosis. So it could be related to that. The flip side is that when you're in AFib, you lose that atrial kick. So, that the gradient might actually go up a little bit depending on the contribution of atrial filling in that setting and how much the atria are really contracting in the presence of significant mitral stenosis. It may not be contributing that much to forward output. So Fast forward to now with the most recent update for the valve guidelines. So now there's all these stages of valvular heart disease. So now severe is classified as a valve area of 1.5 or less. So that's the new guidelines, right? Flora's nodding because she just studied like gangbusters for her Royal College cardiology examination. So and it kind of fits with that concept that because we were intervening on patients, and that was the cutoff, that we would call what less than 1.5 severe. This way, everybody could feel good about intervening on less than 1.5 because you're not intervening on moderate mitral stenosis. It's kind of how where ICD guidelines cutoff of 30% became the cutoff of EF for severe LV dysfunction was 30%. And back when I was training, we didn't call severe LV dysfunction until the EF was less than 20%. It was kind of weird. So there's a change. So yeah, you guys don't even know those days, right? Kim knows. Kim's nodding because that's you always remember things when you were training because you were studying so hard for exams. That's when your knowledge base was really at a high point, right? So now the guidelines focus on valve area less than 1.5, and then very severe less than 1. And then they also have the pressure half times, but the pressure half times correlate with the valve areas. So like for asymptomatic or symptomatic or asymptomatic severe mitral stenosis, it's a valve area less than 1.5 or less than 1 is very severe. The diastolic pressure half time of greater than 150 milliseconds, which essentially equates to valve area 1.5. Remember the equation for mitral valve area by pressure half time is 220 divided by the pressure half time, right? So that's why very severe is greater than equal to 220 milliseconds pressure half time because that equals to mitral valve area 1. And then you have secondary hemodynamic consequences, RVSP, left atrial dilatation. So it's interesting. They actually kind of took mean gradient out of the quantification of severity, which for anybody doing echocardiography is like, well, that's ridiculous. Like, because we talk about the gradient all the time. We measure the gradient; it's important. So it's not to say that you ignore the gradient. I think you measure the gradient. You use the gradient to determine severity, but you recognize the caveats behind that gradient. So, and the reason they took it off because we know that the transmitral gradient, while it's usually greater than 5 to 10 in severe MS and usually greater than 10 in true severe mitral stenosis, there's lots of variability depending on the heart rate, depending on the forward flow, that stroke volume that goes through that mitral valve. And because of that, it wasn't directly included in the criteria for severity because we know it can change it. In part, it's similar to the mean gradient across the aortic valve in aortic stenosis, where we have this big category of low flow, low gradient, and we separate the classic low flow versus paradoxical low flow. So it's a factor, but it's not the same. You can't call severe mitral stenosis because the gradient is 5 or 6 millimeters of mercury. Does that make sense? Yep. So just in terms of all the different things we look at assessing the severity, mitral valve area by perimetry, it can be accurate if done correctly. It's independent of other factors, especially if you use 3D technology. Here, Dr. Chow. But it's technically challenging. You want to try and measure that smallest orifice. Tracing around calcification is difficult, poor acoustic windows. Pressure half time, relatively easy to measure if it's a fairly linear slope. But it's dependent on so many factors. Aortic regurgitation can affect pressure half time, where it can shorten the pressure half time. LA compliance, LV diastolic dysfunction can affect the pressure half time. Mitral valve area by continuity equation. A lot of previous studies use that as a gold standard, but because it's independent from flow conditions, but it requires multiple measurements, lots of different sources of error. We don't do it clinically in the echo lab. And you can't have significant mitral regurgitation or aortic regurgitation. Similarly for PISA, technically difficult to perform. There's always an angle correction that you probably need to do, but we don't do it routinely. The mean gradient we talked about is easy to perform, it's consistent, but it's dependent on the heart rate flow conditions can change. RVSP easy to perform, but there's caveats to that as well. You have to estimate the right atrial pressure. There's some challenges with that in terms of how accurate it is, and you don't estimate the pulmonary vascular resistance. And then once again, you can look at the exercise response. And the ones that are highlighted in yellow are kind of our go-to, like routine parameters for assessing severity of mitral stenosis. Flow telemetry, pressure half time, mean grade, and RVSP. That's pretty much bread and butter for mitral stenosis assessment, right? So let's look back at this echo case. So the mean grade is 6 to 7 millimeters of mercury, had a decent heart rate, 71 beats per minute, not too high, not too low. So it's a good average. So the mean grade would suggest moderate mitral stenosis if we looked at the 2009 guidelines. And the caveat from the 2014 valvular guidelines is that it doesn't exclude the presence of severe mitral stenosis. This could be compatible with severe mitral stenosis. Then you have the two measurements of pressure half time that we standardly use. Telemetry suggests severe, 1.4 to 1.5, but the mitral valve area by pressure half time suggests more moderate or not severe mitral stenosis. And the RVSP is kind of like, right, knowing that you could have pulmonary hypertension related to other things, and then you have this atrial septal defect, for example, that might be driving things. So some of the things to recognize that might affect some of these measurements and change the validity of the estimation of severity based on these parameters include the presence of the atrial septal defect. So what does the ASD do? The ASD essentially shunts blood from the left atrium into the right atrium throughout the cardiac cycle. And because of that, it takes away some of that left atrial blood that normally would go through that mitral valve. And then theoretically, it could lower the mitral valve gradient that we're measuring in the presence of that atrial septal defect. And similar to low flow, low gradient aortic valve stenosis, could it reduce the opening of that mitral valve? And if you had that volume that went from left atrium to right atrium, go through that mitral valve, maybe that mitral valve would open up a little bit more as well. So that's also a possibility. There's a hypertension. She's significantly hypertensive. She's on 2 antihypertensive agents. So could there be some LV myocardial properties that affect the pressure half time? Because if you have LV diastolic dysfunction, high filling pressure in the left ventricle, you can shorten the pressure half time where there's more rapid equalization of pressures between the left atrium and the left ventricle during diastole, short pressure half time. And that would lead to an overestimation of mitral valve area. So the mitral valve area by pressure half time may be greater than what you expected if the LV compliance was completely low. And as well, hypertension, LV diastolic dysfunction can increase left atrial pressure, and that can drive more blood through the atrial septal defect. So lots of different factors in this. And just my caveat at the bottom is that just remember, pressure half time is best valid in rheumatic mitral stenosis with a completely normal left ventricle. So in typical rheumatic MS, without hypertension, the LV is small, it's very compliant, and that's where it's best validated. And we probably shouldn't use pressure half time in other settings. Can't use it for mechanical mitral valves. You can't use it for prolapse, for example. And you probably shouldn't use it in setting of LV systolic dysfunction because filling pressures are probably elevated. You probably shouldn't use it in the setting of true heart failure preserved ejection where there's hypertrophy of the left ventricle and there's LV diastolic dysfunction. So pressure half time is valid for mitral valve area really in a pretty small subset of patients, but we still use it routinely. But you've got to know the caveats.
I guess the other one maybe the IOI as well.
No, yeah. So mild to moderate. So probably, but yes, definitely the aortic regurgitation definitely can affect the pressure half time as well, for sure. And that might kind of similar to LV diastolic dysfunction. It can lead to higher diastolic pressures and shorten that pressure half time and lead to overestimation of the mitral valve area, for sure. Yeah, agreed. Okay, and then what about the atrial septal defect? There's some diastolic septal flattening, there's a degree of tricuspid regurgitation, but there's also flow from the left atrium into the right atrium. The RV doesn't measure dilated, but in the setting of mitral stenosis with a fairly small left ventricle, it looks like it's probably dilated at least in comparison to the left ventricle. we actually lean on RV dilatation to look at the significance of an atrial septal defect, partly because our measurements of QPQS is confounded by lots of potential errors. Okay, so what are the next steps? So, what do you think? So you get this conundrum, you're thinking about an intervention upon this mitral valve, and just to make it more complicated, there's a few other factors that probably not a good candidate for another valvuloplasty. So you're looking at valve replacement. So Rishi, do you think these limitations of pressure added by ESC has not changed your opinion on mean gradients? Yeah, no, I think that's, I think there's no gold standard per se. I think we have to use all the measurements that are in our toolbox. But I think, there's lots of reasons why the mean gradient doesn't. Sean goes for controlled blood pressure catheter hemodynamics. Okay, all right. So, I don't think right now there's probably not enough data to say yes, we have all the data we need to intervene upon. So we need to get more data. So we've done a transthoracic. So what other tests could we order? For sure, I don't think a T would offer us that much more at this stage. So I think cath hemodynamics would be useful. But once again, there's lots of different factors in play, so you have to be careful. So here's went for a cardiac catheter. Here's the PA pressures. So it's 74/39 millimeters of mercury. So severe pulmonary hypertension, and the mean greater is 51. And here's the LV pressure tracing. So hypertensive in the cath lab, so 157/7, and diastolic pressure of 21, which is elevated. So here's the simultaneous LV, LA, or wedge pressure tracing, and the mean graded is 7 by cath. Actually correlates nicely with echocardiography, usually does. And the valve area by Gorlin formula is 1.3 square centimeters. I'm not sure if Dr. Chisholm did this cath or he helped kind of guide the cath with the colleagues. So they put a balloon across the ASD and they temporarily occluded it. And so with the occlusion of the ASD, the mean grade across the mitral valve has now gone up to 13 millimeters of mercury, which is now clearly in the severe range. So it kind of nicely shows the effect of the atrial septal defect on the mean grade across the mitral valve, just purely flow-based. So this patient went on to have mitral valve replacement, closure of the ASD, and a tricuspid annuloplasty ring. And did well. So the take-home message is, so when valve parameters don't fit the clinical scenario, or when the echo parameters are discordant, you have to examine and recognize all the potential pitfalls of these measurements and these assessments. The mean gradient depends on heart rate, flow conditions, pressure half time, multiple factors, aortic regurgitation, LA compliance, LV diastolic dysfunction, mitral valve area by planimetry, technically challenging, smallest orifice calcifications, poor acoustic windows, and perhaps reduced opening in the setting of reduced stroke volume through that mitral valve. We're getting better and better at measuring mitral valve area by planimetry. I think 3D has helped. We do it with T a lot. And in this patient, actually, the mitral valve area actually suggested severe mitral stenosis when we did it by even 2D planimetry. So maybe we should have leaned more on that, recognizing the caveats. And in this case, the elevated LV diastolic pressures, left atrial pressures, because of hypertension, probably led to greater shunting and led to that dilated right ventricle. So these are all factors that kind of mask the MS severity. So that's that case. I don't think I'm going to get to the third case, but that's okay. Always happens, right? All right. Perfect. I've been trying to keep a track of the chat. Hopefully, let's see. Lisa, okay. Yep. Yep. Okay. Yep. These are all comments we sort of covered. Yep. Perfect. No, love the comments. Thank you. Okay. So This is a case of aortic regurgitation. It's a patient of mine, actually. So I might have shown this case before, which I'm going to remember, but it might trigger some bells. So a 65-year-old man with hypertension, previously mild to moderate aortic regurgitation, has a pacemaker implanted for heart block, and was seen in the pacemaker clinic in 2013 with increasing exercise intolerance, initially intermittent, then more continuous, and then had some episodes where he woke up at night with shortness of breath. And he's on aspirin and Diaban. On physical exam, he's got a murmur of aortic regurgitation, a short systolic ejection movement. GFP is not elevated. He's borderline hypertensive, and he was seen in the pacemaker clinic, and they ordered a stress echocardiogram. So here's some resting parasternal long axis. So for those astute in you, knowing that it's an AI case, you notice that there's reduced opening of the mitral valve, probably related to aortic regurgitation. Thickened cusps of the aortic valve, the anterior cusp or the right coronary cusp is relatively mobile, but that posterior cusp or non-coronary cusp moves quite well. And there's eccentric aortic regurgitation, predominantly posterior directed. There's a small anterior directed jet as well. There's the apical 5-chamber view, 2 jets. Trying to get an AI pressure half-time, always more difficult in the presence of an eccentric jet. But it suggests a short AI pressure half-time here of 183 milliseconds. Although the caveat is you're never sure with eccentric jets if you're catching the complete envelope, right? There's a whole diastolic flow reversal in the descending thoracic aorta, which you can here. Although the end diastolic velocities are not, they're not very elevated. We didn't measure, but they're not very elevated. But I think we all agree that there's full diastolic flow reversal here in the descending thoracic aorta, but maybe not the abdominal aorta. It's difficult to get parallel to flow or near parallel to flow with the abdominal aorta. When we can get it, it's a really nice pickup because it's actually quite specific for a severe aortic regurgitation. You can see a bit of flow reversal by color valvular. Okay, so what is the severity of aortic regurgitation in this case? What do you think, Flora?
I think the presence of the hollow diastolic, even though if we may be not catching a full Doppler jet, but the presence of hollow diastolic flow reversal, at least in the the descending thoracic area, would suggest to me at least moderate to perhaps severe as well. And then, although we're not picking it up in the proximal area, but that's the LV looks dilated as well on that initial peristernal long axis. So by those parameters, and it looks very difficult to be able to quantify by PISA or contracta. So, but the presence of that, I would say, at least moderate to severe. Yeah.
So I probably would have called it moderate to severe. I think moderate is like the starting point. So I wouldn't call it anything less than moderate. So my standard would be moderate to severe. Then think about a T to further quantify, and or CMRs as useful technique as well. Okay. So the patient had the stress echo, wasn't ordered by me, but here's the stress echo. So I'm not sure if anybody wants to comment on the stress echo. Yeah. So I agree. So this is rest, intermediate stress, peak and post. Dilates gets worse, right? So there's definitely a reduction in the LV systolic function, reduction in the LVF of parasternal long axis. So compare here to here. Okay, so did use contrast, although in today's echo lab we would use contrast for sure, right? It was he's laughing. He's like, how come they didn't use contrast? Oh my gosh! Back in 2012, right? 11 years ago, we were using now. Well, especially the image quality is not perfect. Well, it's not. It's close to 100%, right? So, but definitely dilated.
99.9.
All right. This is circa 2012 stress echo. Thanks. So okay, so definitely a reduction in the LVF. Has hypertension at rest. Was hypertensive at peak stress 215/99. So that's a caveat in all this with regards to so-called false positive stress echoes. Although we heard from the guidelines. You gave the guidelines, the stress echo guidelines for ischemic heart disease, or was it Ashman? Talked about that. People don't no longer talk about false positive stress echoes for hypertension, right? So we do see it regularly. Not regularly, we do see it. Okay. All right. So so we came. So this is just a follow-up echo after that. So the LVF back to normal or low normal. So here the AI looks a little bit worse than before actually. Posterior directed again, a short axis view. It's a tricuspid aortic valve. It's not bicuspid. That's what you're thinking. It's a good thought though. Oh yeah, so Joshua was saying that. Yeah, so thank you for that, Joshua. That's a good tip actually. And we talked about this before. Is that because the alignment here with this eccentric jet, you could do CW across this. I think we would do this in our lab. At least I hope we would do this across the lab and it holds the same with eccentric mitral regurgitation. Sometimes if there's anterior pullout with a posterior directed jet or posterior tethering with a posterior directed jet, you get very good alignment for CW with of the parasternal long axis, both for AI and for MR, where you couldn't get it with the apical views because they're less parallel on the apical views with these very eccentric jets. So, for example, if you wanted to even measure PISA here with CW and on a Doppler, you theoretically could try a PISA, probably not validated in terms of trials, but from a theoretical standpoint, probably you possibly could do this because you're actually quite parallel. So you can actually see the flow convergence here, where you could align yourself and really get a nice dense CW jet and look at pressure halftime here. The only caveat, of course, is that pressure halftime for AI severity was probably not validated off the parasternal lower axis. I'm pretty sure all those measurements were done of apical 4, apical 5, or apical 3 chamber views. So, and this kind of goes to Joshua's point here. When you look at this CW jet here, we're trying to align best, but you're almost perpendicular to flow, and at least the cursor alignment when the recording started is not even across the LVOT. It's kind of more across the LV, and that's done to try and pick up the jet as it's become more parallel to flow. Because if you move the transducer to where the AI jet originates, because it's more perpendicular to flow, you're probably not going to pick up a lot of signal. Just obviously for Doppler measurements, you have to be as parallel to flow as possible. So here it looks fairly incomplete. So the AI pressure half-time may not be accurate here. Here's the apical 3 chamber. It was, I think, in the low 50s. So here's actually there's probably less holodiastolic flow reversal in the descending thoracic aorta compared to before, and not really in the abdomen. So same questions as before. Not sure for further ahead. It looks more severe visually from a color Doppler standpoint. So maybe at the very least, I think moderate to severe is pretty safe. And all echocardiographers have their threshold for qualitative / semi-quantitative analysis. Some would call this severe, some would call it moderate severe. So I try to tend to report a bit more specific. So I wouldn't call it severe unless I was fairly sure it was severe. And if I wasn't sure, then I'd call it moderate to severe with the usual caveats, and then recommend that other techniques, either a T or a CMR to quantify. But some may just call it severe if it's possible. Props to the echo tech. Okay, yes, that's okay. That's always good to give props to the the sonographers to these excellent images for sure. We definitely rely on them for excellent images, right, Kathy? Okay, so aortic regurgitation severity. This is familiar to everybody. The specific signs for severe, we talk about a width of 2/3 the LVOT, vena contracta of 0.6 centimeters, short pressure half time of 200 milliseconds, full diastolic flow versus descending thoracic aorta, coupled with moderate or severe LV enlargement, especially in the presence of chronic aortic regurgitation. And if you want to do PISA calculations for regurgitant volume, fraction, EROH, SOGR 60, 50, and 30. And the more recent guidelines in 2014, so severe, pretty similar. Jet width 2/3 the LVOT, vena contracta greater than 0.6 centimeters or 6 millimeters, that full diastolic flow versus the proximal. I should say, I guess definitely the abdominal aorta, but it could be in the thoracic aorta as well. The PISA measurements, and then severe requires LV dilatation. All right. So I don't know if you noticed actually, but there's a phenomenon here that kind of points to at least a potential hemodynamic reason why you'd call it severe. It has to do with the mitral regurgitation. So what's up with this mitral regurgitation? It's diastolic, yes. So it's occurring at the same time you see the aortic regurgitation, which is unusual. So this is diastolic MR. This is a lot of, I think this is like Jeremy's favorite echo thing. It's diastolic. He talks about diastolic MR. I know Dr. Chow also likes diastolic MR. I like diastolic MR too. So what does diastolic mitral regurgitation mean in this particular context? What does it mean?
LVEDP is very high.
Yeah, exactly. So this tells you that at the end of diastole or somewhere during diastole, pressures in the left ventricle are now greater than pressures in the left atrium. And in this case, it's because of the aortic regurgitation. So, and actually there was a hint, you saw it best here, but even here, and a lot of times you're so focused on that AI, you say, oh, there's trace mitral regurgitation. But the MR here is in diastole because you can see it, or you can see the aortic regurgitation. It's not quite in, so, all right. So now patient had a transesophageal echo, and this is X-plane imaging through the aortic valve. So you can see that, look at that beautiful flow conversion. See, that's like gorgeous. So now, don't forget, everything is upside down on TE. So this is posterior, that's anterior. So this is a posterior that jet right at the base of the anterior to the mitral valve. So here, and this is the Joshua's point, here's CW, continuous wave Doppler, on T, parallel to flow. And you can see how short this pressure half time is. It's actually even shorter than we got on the transthoracic echo. And here's the cath measurements. Patient went for cath, had normal coronary arteries, so you wondered about that abnormal stress echo response. So normal coronary arteries. So this is stress echo showing LV dysfunction brought out, LV dysfunction from severe EI kind of brought out by stress. So you see the LVDP was 48 millimeters of mercury. So that's high, right?
Yeah, very.
That's right. Okay. So now you can understand why that space was short for that, right? So anyways, he went forward for a bioprosthetic aortic valve replacement. He's done well, actually. So we're coming to an end. I'll save the third case for another one. I'll build another one, heart failure. I'll focus on LV dysfunction. The other case is a great case too. So for AI severity, you need to integrate all the findings for assessment, examine, recognize potential pitfalls very similar to mitral stenosis. Semi-quantitative measures have good specificity but low sensitivity, and then T can be helpful for further assessing severity. This is a nice paper from David Messica-Zeytoun, published in JACE in 2011, comparing the 4 semi-quantitative measurements, LV cardiac output by echocardiography that follow diastolic flow reversal at the arch level, so the proximal descending thoracic aorta, vena contracta in 224 patients with aortic regurgitation. And this study used the usual caveats. Use PISA calculation as the gold standard for what we call severe. And here is listed as the sensitivity, specificity, and the positive and negative predictive values of some of these measurements. So, if the stroke volume cardiac output is very elevated, then it's up to 89% specific for it. The short pressure half time of less than 200 milliseconds, if it's a good tracing, etc., is almost 100% specific for severe EI. It's not very sensitive, meaning in the absence of you could have severe EI even if it's greater than 200. Essentially, what the poor sensitivity means. They use a cutoff of end diastolic flow reversal of 18 centimeters per second, which is actually fairly low. But if it's present, it's like 87% specific in this 224 patients, and then the vena contracta, pretty decent sensitive specificity. So if you get a good vena contracta, it might be a good adjunct to some of the other things that we do normally. The one thing I would say, just if you're actually going to measure the end diastolic flow reversal and look for that cutoff of 18, or in our lab we tend to use 20. 18 is a bit of a funny number. You just have to be very careful with the settings. Janice is here. Janice always talked about the wall filters and the Doppler gains. You have to be very careful you don't overgain. Check your filters because you don't want to necessarily call it. And I personally, I almost never call a lesion severe based on one finding if everything else fits less than severe. So you have to use everything in combination. All right, so I'm going to save my third case, which is a longer case for another time. So yeah,
just put a concern that we do, like you said, the LV dilatation with 3D or 2D with contrast, because generally when she was a fellow, she did a nice paper, definitive paper, but it showed that that in chronic AI was helped you actually then determine the severity, and in fact it helped determine the degree of ventricular remodeling. We can use that to determine the likelihood of a successful repair on developmental fixed and reverse remodeling. So you really do need to look at the volumetric assessment. Now the guidelines will talk about if they're too old, they're going to have to be redone. It's just we're trying to acquire all the data. So we always need to do it exactly the same as what you would with MR. We need to do quantitative assessment. And the other thing I think with the PISA, once you see a PISA, you know there's significant disease. And that, of course, that's the highest likelihood. Once you've got a PISA, you've got Rich Nyquist limit. So if you can get your EW through that, that's likely to then show you your true peak velocity. Every off that, remember with the Doppler effect, every degree off, you're at about 1% off the true velocity. So that is actually telling you where you want to put your CW to go through. So there's nothing wrong with actually playing around with the baseline, showing where it is, and then using that to target the CW. It's going to try and get you a better profile to more accurately measure your pressure half time. So fairly easy to do. And that's why the PISA is such a useful technique when you can actually get angle.
Yeah, no, I agree. So just make sure everyone online heard Dr. Conley's comments. So the first comment with regard to assessment of LV dilatation, particularly LV volumes, 2D. If you're lucky enough to be able to do 3D, then probably even better. It kind of goes to it's one of the parameters we look at for severity of the eye, and then it also helps in terms of driving intervention because we know that these cutoffs for LV dimensions about when to intervene upon severe AI in the asymptomatic patients, for example. There's a severity index that Geraldine studied as well, and then the PISA assessments. I think we always know that even if you're not going to measure PISA and do the full quantification of the EROA, regurgitation volume, etc., just the presence of that flow convergence, whether it's EI or MR, at normal Nyquist settings, already tells you that there's significant regurgitation, and then you could think about dropping the baseline and actually doing some quantitative measures. So these are great tips. So thanks, Ken. Yes, Kathy.
So for us sonographers especially now that we're having like new sonographers, can you please enlighten us why do we need to do contrast when there's like significant MR and AR? Because some they would think if they get like kind of like nice and the cardial definition, it's like, oh, they can trace this for LVEF. So even like most of us would say, okay, if we have significant MR, AR for volumes, we need to do contrast, even if you think like, I mean, the pictures are good.
Yeah, so I think it goes to the threshold as to how good the endocardial definition is to allow accurate tracing. And I can tell you as a reader, and part of it is your experience as a reader, it's way easier to trace in the presence of good contrast LVO. In the absence of contrast, depending on how much trabeculations you are, sometimes you're not sure. I think part of it is that we trace more often with contrast than without contrast, so we're more confident with contrast tracing. That's one thing. But I think contrast is a tool in our toolbox. I think it's an important tool. I think we should use all the tools as possible to get the best quality data. The caveat is that contrast gives you better EF assessments. It gives you better volume assessments, but all the normal values we have are for non-contrast. So we have to recognize that contrast volumes in normal patients are greater. We're trying to get more data as to what those normal values are for contrast. But and that volume and EF assessment in chronic severe regurgitation, whether it's MR or AI, are important because that drives intervention even though patients are asymptomatic. Which is one of the reasons why I think Jeremy probably Jeremy talks about getting LVEF assessment and contrast with MR more than any of the other attempts. So so it is important. So I do think we use contrast for LVEF assessment fairly routinely in our lab. Could we use it more? I think we probably could. So I think we still underutilize it as well. Recognize the challenges for both, but we definitely underutilize.
Does the number same contrast that we without contrast and
there's the same cutoffs of normal, yes. Just more accurate with contrast.